All right, thank you, Rachel. Good morning. This is Committee Member Sellers of the Public Health and Pharmacy Formulary Advisory Committee, and I will now call this special meeting to order. Today is Tuesday, January 27th, 2026, and it is 9:03 a.m. Public Health and Pharmacy Formulary Advisory Committee meetings are conducted in accordance with the Oregon Public Meetings Law. Under the Public Meetings Law, governing body meetings are open to the public except as otherwise provided by law. The presiding officer has the authority to keep order and to impose any reasonable restrictions necessary for the efficient and orderly conduct of a meeting. Governing bodies are authorized by ORS 192.660 to meet in executive session in certain limited situations. All official actions by the committee must be taken by public vote, and the vote of each member must be recorded. I will now take roll call. For the record, when I call your name, please verbally acknowledge here. Committee Member Lorinda Anderson.
Here.
Committee Member Andrew Gibler.
Here.
Committee Member Courtney Sellers is here. Committee Member Sarah Wickenhagen.
Here.
Operations Manager Rachel Melvin.
Here.
Executive Director Gary Runyon.
Here.
We will now review housekeeping.
Oh, I'm sorry, Courtney, please, you need to, for the record, you need to state that the other two committee members are excused for today.
Oh, okay. Committee
Right.
Member Catherine Hammond is excused and Committee Member Robin Virgin are excused from the meeting today. We will now review housekeeping, meeting etiquette, and public comment information. Committee members and staff, please silence all devices. Identify yourself as committee or staff member and then your last name each time you speak. Please speak clearly and one at a time as it is critical for the public record. Please note that this meeting is being recorded and retained for public record keeping purposes. Public comment, when applicable, occurs toward the end of the meeting. The committee will not deliberate any issues or requests during public comment, such as formal requests or currently proposed protocols. We will now review the meeting agenda. Committee Member Anderson, do you have any proposed revisions to the meeting agenda?
No, I do not know.
Committee Member Gibler, any proposed revisions?
No.
Committee Member Sellers has no proposed revisions. Committee Member Wickenhagen, do you have any proposed revisions?
Thank you.
All right. Is there a motion to approve the meeting agenda as proposed?
I motion to approve the meeting agenda.
Committee Member Gibler seconds.
Thank you. And we'll do a roll call vote to approve the agenda. Committee Member Anderson.
Approves.
Committee Member Gibler.
Approve.
Committee Member Sellers approves. Committee Member Wickenhagen. Oh, Committee Member Wickenhagen.
Approves.
Thank you. This motion passes. Is there any discussion on proposed meeting summary from January 15th, 2026? If not, is there a motion to move to approve the January 15th, 2026 PHPFAC meeting summary?
Committee Member Gibler so moved. Sorry.
And Committee Member Wickenhagen second.
Excellent. We'll do a roll call vote on approval or to approve or not approve the January 15th PHPFAC meeting summary. Committee Member Anderson.
Approve.
Committee Member Gibler.
Approve.
Committee Member Sellers approves. Committee Member Wickenhagen. Oh, Committee Member Wickenhagen.
Approves. Sorry, there must be a little delay. I apologize.
That's okay. This motion passes. All right, we will begin our review and discussion with mailing A regarding medications for opioid use disorder, starting with Executive Director Runyon. Please take the floor.
Good morning, everyone. Executive Director Runyon. We'll start with the mailing A, and I'll wait while staff member Melvin gets that pulled up for you.
Okay, so do you want to just, I'm opening patient intake form, not the cover page. Okay.
Yeah.
All right. Can committee members see the Word version of the patient intake form?
Yes, we can.
Okay, super.
Okay, from the last section or the last meeting, I think the highlights that are teal-ish that we were directed to incorporate during the meeting are there, and then the yellow ones are they were embedded in the document prior to sending that to you. So we'll just go down and give you a brief overview because we've all slept probably a little since then. Number one, you'll see the teal highlights in bullet point 4 and 5. And we just made the language a little more user friendly. So bullet point 4, for example, says difficulty keeping up with major responsibilities because of opioid use, so at home, work, school, etc. And bullet point 5 will be continuing to use opioids even when it causes problems in your personal life or relationships, parentheses with family, friends, people at work, etc. So again, just modifying the language at the committee's directions to make it a little more user-friendly. We'll continue down. No modifications to question 2. And we eliminated question 3, fixed a typo in question 4. We unified the language about liver function between all of the documents. So we're combining the question about liver failure, cirrhosis, and jaundice or yellowing of the skin. So that language is consistent between all of the documents there. We'll scroll down. We removed all of the mental health questions, and we took those off of the treatment care pathway as well. And we modified the chronic pain question, and we made a slight amendment to the treatment care pathway to reflect that as well. We removed the pregnancy and breastfeeding question because it wasn't a contraindication to therapy. We retained question 13 about the confusion, dizziness, fever, chills, etc., just highlighting the fact that the patient thinks it's unrelated to withdrawal symptoms. And we kept the medication history question, modified the note at the end, and we removed the SOS assessment. And we added potentially for potentially lethal additives to the test strips as directed. Continue further down. And that was just an internal note there. Of course, we got rid of that in the last meeting. No changes to the patient attestation. And then we just removed a couple of things per the committee's direction there, as the pharmacist will be filling this portion out and don't need any help with the dosage form and dose there. Good call. And here's the pharmacist signature. And I'll turn it back over to the committee for any questions on this before we move to the treatment care pathway to look at the corresponding changes there.
Thank you. This is Committee Member Sellers. Any discussion on the revisions that were made?
The committee member working again, I just want to acknowledge my appreciation for all of that hard work. I think this looks phenomenal. Thank you very much, board staff.
Yeah, appreciate that. It's very readable now. I think it'll be very easy to use now.
Thank you, committee members Wickenhagen and Gibler. Yeah, I think that we can move on to the next section.
Assessment and treatment care pathway.
Okay, Executive Director Runyon. Thank you for the compliments. I would like to thank Staff Member Melvin and Staff Member Efremoff for putting in the work to make those amendments as well and for taking good notes during the last meeting. So we'll continue with mailing A, the continuation or modification, or the treatment care pathway for initiation or reduction of therapy. So we took out the essentially the criteria summary up top, and because we didn't have that in other protocols. Scroll down here. Removed all the red and green. There may be some additional formatting modifications to more closely mirror what we have in other protocols. But I do agree removing the red and green makes it a little more user-friendly there. So we kept the question about the age, kept the question about medication allergies and opioid use history. Scroll further down. And then we modified the wording of this question number 4 to mirror the other changes related to the liver function questions or the history there. We modified the treatment pathway there, referred
Do you
to
want to
another.
justify? I'm sorry. Do you want to justify left on number 4 like you are with the other questions?
Yes,
Thank you.
this is Staff Member Melvin. I am going to go through all of these documents before we prep them for our board meeting.
Oh, okay. I saw you do it with the
Remember, Gebler?
previous
So there-
question. So
Yeah, and you're
Sorry.
going to see me like get rid of. Sorry, I was just doing that while Gary was going through
I'm
it.
sorry. Sorry to
I'm going to
interrupt.
justify. No, you're totally fine. And I will renumber everything. So thank you.
Executive Director Runyon, we removed the suicide risks questions. As well as the question about any acute crisis, because it, again, would not be a contraindication to therapy. And then number 7, we slightly modified the treatment bifurcation there, stating that the pharmacist must notify the prescriber. And again, to highlight, it isn't a requisite of continuing through the pathway that they notify the prescriber before they prescribe. It's just they must notify the prescriber as a part of the protocol itself. So again, it's not requiring that they notify the prescriber before the prescription can occur, which is, I believe, is standard of practice for other prescribing providers as well. And number 8, acute illness. Those changes reflect what we did in the patient intake form. Go down a little further. And we have the removal of the SALS assessment, which we did in the intake form as well. Further. And no changes to these. It's just the health and safety resources and harm reduction tools. Inquiries. Further. Patient attestation and PDMP review. No changes there.
Did I go too fast? Sorry.
No, sorry.
Okay.
Okay, and here's where I think we can really pick up with some more of the discussion for today. SME Emily Skogran was gracious enough to, again, donate some of her time to create a patient handout that'll really give a little more depth to the patient instructions, when to start, what to look for, what to expect, how to modify treatment according to their symptoms, etc. And then the generic SIG that will likely, for the committee's approval, go on the label to correspond with that patient handouts there. And follow the instruction sheet and take 1 to 2 tablets under the tongue 1 to 3 times daily. Of course, the max is 4 tabs on day 1 or 3 tabs per day thereafter. And then you'll see that reflected in the sheet that Emily's going to go over. And then the comment, I took some of the comments out because they were just too expansive, too detailed to include, and they're going to be covered in the patient handout anyway. So, Smee, Emily, would you mind to pull that up or?
Sure.
Yeah, of course. I think I sent it to Rachel, but I can share it too if there's.
Oh, give me just a moment and I'll pull it right.
Great. So I used essentially the Scalar Northwest. It sounds like you guys really liked that last time, and I agree. It was a really good patient-facing handout. But I think there was some changes that we wanted to do, and then also if we wanted to have the initial starting dose being 8 versus 16 milligrams. So I thought it just might be easier if we created our own, and that way we can really tailor it to what we want the dosing strategy to be. This is just a rough draft. I will certainly make it look much prettier. I just didn't want to spend a whole lot of time on it if it was not something that everyone felt like it was important or reflected what we wanted to do. But essentially it has on day 1, and we want to make sure you're in moderate to severe withdrawal. And then I did add that extra Scalar Northwest didn't have the certain amount of time to wait after fentanyl versus prescription opiate use versus methadone use. And so I added that little caveat there. And then I just marked it up as 2 tablets, so 16 milligrams as a starting dose, but I certainly feel like we should have a maybe more conversation about if that is really the path we want to go, if we wanted to stick with 8 milligrams and do 8 milligrams every 20 to 30 minutes instead of initial starting dose at 16. I did pull some SMEs, so Bradley Buchheit, he's going to pop on at 11 o'clock. He is an addiction med doctor that is the medical director for our low barrier buprenorphine prescribing clinic. So he does a lot of buprenorphine starts on the outpatient basis. Him and another person that works in Harbor a lot say that most of the time they're starting at 16 milligrams. There's very few patients that they revert and start at 8 milligrams. I also pulled the Nora Englander, who you guys met last time. She said, maybe you start at 8 milligrams and you do that every 20 to 30 minutes. I also spoke with the medical director at Fora, who does also do a lot of buprenorphine starts. They mostly rely on the high dose, 16 to 24 milligrams. Sometimes they do 32 as their initial dose. I'm not recommending that. But she also brought up the ideas that we certainly could do 8 milligrams and repeat that every 20 minutes to a max total daily dose of 32 milligrams on day 1. So I think probably any pathway is right, whatever the committee feels the most comfortable with. The other thing that I added on here, I put the opiate withdrawal adjunct medications. It sounds like we can't have that in our first iteration, so I'll absolutely take that out. And then the Scalar Northwest didn't have anything on there about naloxone. I do think that's an important point to put out there. So I would really love to have some reference to naloxone on this pathway, if possible.
This is Committee Member Sellers. I think this looks great. I love your idea for adding something about naloxone on there. And I also agree that the 16 milligrams, I think, is a reasonable starting dose.
This committee member Gibler, go ahead.
I'm sorry, I was going to say, Chair Sellers, if you could just do a round robin and just get everybody's feedback, that'd be great. Sorry.
This Committee Member Sellers. Yeah, sorry. Go ahead, Committee Member Gibler.
Thank you. Can you explain the visual on the upper right with the blank 4 milligram tablet and the full 8 milligram tablet under the table? It says take 1/2 to 1 tablet.
Yeah, it was really easy to make a circle. Finding a half circle was really challenging for me. So if that was not something that we wanted to do, I didn't want to spend a long time to try and figure that out. But that is the next iteration that I do when it's finalized. I will have a better visualization of a pill and a half pill. Absolutely.
Okay.
Sorry, I should have mentioned that.
No, that makes sense. My only other comment is I believe the font size especially in the yellow tables is too small for some people, and so it looks like you have enough white space, you could probably make that a little bit larger, and that would help people be able to read a little bit better, I think.
Absolutely. Great.
I think that's the only comments I have. Thank you.
Committee member McKinnigan, I agree with those comments, and I also appreciate this document very much. I think it's very user friendly, and appreciate the work that was done on it. Thank you.
And this is Committee Member Anderson. I also appreciate all the work you put into that and would agree with Andrew's comments. And I also am in agreement with starting with 16 milligrams as the initial dose.
Committee Member Sellers, thank you, everyone. I think that this document looks amazing, and I think we can continue on.
Executive Director Onion. Thank you again, Emily, for putting that together. I think it looks great. I think since this wraps up the initiation pathway, it would probably be a good point to discuss at least a couple of the questions that I'd sent out to the committee. Things that we'll have to likely answer to the board, things that will come up out in the community as well about any particular limitations on the initial quantity. I think we had put 28 in there. And to make sure the committee is okay with that. And then particularly addressing what happens if the patient comes back and they're unable to see another provider. Is the pharmacist able to then treat them via the continuation or modification pathway? Or are we going to suggest that they refer to another provider before they can continue care with the pharmacist? So again, to kind of create a synopsis there, is referral to another provider required at this point? Or can the patient come back and continue therapy without further follow-up from another provider with the pharmacist? And committee member Sellers, I'll turn it back over to you.
Thank you, Executive Director Runyon. I guess I would love to ask our SME, Emily Skogrand, what your thoughts are on those two questions.
I mean, I would love it if we were able to continue it. And if the pharmacist feels comfortable in doing it, I think that's something that is certainly within our wheelhouse, and we are medication experts, and to be able to adjust it or, to really work with a patient to continue it, I think would be huge. Also, just thinking about rural parts of our state where it's like, I can't even get into my PCP within 28 days, let alone a buprenorphine prescriber, I think would be quite challenging if we limit it. The alternative that we can offer is that if we do limit it, there are low barrier buprenorphine telehealth clinics. Telehealth is not an option for some people that don't have a smartphone, but there are a few telehealth clinics that we can keep in our back pocket as referral if we do want to restrict how long the pharmacist can prescribe it. But I feel like that could do some patients a disservice.
And this is Committee Member Sellers. From the two questions posed, I do like the quantity of 28 that's being dispensed, and I agree with SME Emily Skogrand about being a little bit more open to moving into the next protocol if needed, if there is a barrier to access. And I'd love to hear from the other committee members. Committee Member Gibler.
Yeah, thank you. Just a couple of questions. What was the original intent of the legislation? Was that to perform as a bridge to care or to actually chronically care for patients? And I forgot my second question, but I'll remember maybe later. But as long as the intent of the legislation was that we would, as pharmacists, actually care for these patients on an ongoing basis, and that was fine. I completely agree with the comments already that many pharmacists are already capable of that. It's just a matter of if they have the time and everything. But and I'll think of my second question.
Committee Member Anderson?
I definitely agree that regardless of whether or not it was meant to be a bridge or whether or not it was meant to be chronic therapy, that we're going to need to be able to prescribe again beyond just once, even just sort of back to what Emily brought up, and that there's a high chance that they're not able to get in to see somebody just yet. And I don't know that there is going to be the best way to like verify that they're able to get in to see somebody, and what if they aren't able to get in to see somebody ever? So I guess I don't know, but I am definitely in agreement that I don't think we should throw limits on it.
Committee Member Wickenhagen?
Having a hard time with that mute button. Committee Member Wickenhagen, obviously this is has all these other layers and complications about being able to refer and where we can refer. And I guess I just think about advice I would give a colleague as a prescriber in their clinic. And I would just say, because we have to bridge people all the time, right? Like they're waiting for a mental health provider or what have you. And the advice that I give them is document that you're a bridge and you've recommended that they seek care, but they're unable. Just some sort of something in your documentation that indicates you acknowledge that it would be in their best interest to have specialty care, but they're unable and you're continuing to bridge. And I don't know what the committee thinks about that, but that's something that I recommend to my colleagues, just so you have the documentation. But if there was some short little something that you could add. But again, I think the bigger picture here is making sure these people get treatment. Thank you.
This is Committee Member Gibler. My other question was, if they're already under someone's care for opioid use disorder, what should we do? And to me, there needs to be some communication with that provider, whether they agree to transfer care to the pharmacist or take over. And because if they're not able to access, sometimes just letting the provider know, hey, they've come to me for care, I've prescribed buprenorphine, because they can't get in, that communication could alert the provider to take action too, if they're already under care with someone else.
Yeah. Executive Director Runyon, thank you for all of that helpful feedback and insight and all of those questions. Committee Member Gibler, I'll address in as much as I can your question about the initial legislative intent. And I think that, of course, it's not legal advice. I think that goes all the way back to the verbiage that was in House Bill 4002. And then it was posed as a essentially continuation of therapy or early refills. So it did imply that the patients had a previous provider, a current provider, and the pharmacist could continue therapy that had already been started. These patients that had arguably been evaluated by a previous provider. As far as evaluating the legislative intent of what is now Senate Bill 236, it's a little more difficult and convoluted because we have at least a couple thousand comments on 4002. We have the language there. Then that was rolled over essentially into our House Bill 3046. Then we worked with OSPA to use their vehicle, which was Senate Bill 236. So it's a really long, convoluted pathway. And speaking with my internal counsel, it would take a lot of work up to get to that point. And I don't have any other insight outside of that. What I can also tell you is that in speaking with some of the senators kind of on site down in Salem that had questions and concerns about this bill passing without any further restrictions. Their primary concerns were the lack of required referrals so that patients could receive longitudinal care, the lack of a formal diagnosis, the lack of the ability to do lab work. And as committee member Wickenhagen pointed out, it's common to, when you're providing a bridge for someone, to make those recommendations. And pharmacists certainly have the ability to do that and to make that documentation internally and in that patient's chart. But is that sufficient? And would it be okay to protect or shield that pharmacist from liability if the patient does choose to continue therapy with the pharmacist without those formal workups or without that longitudinal care or additional resources, et cetera? So again, to kind of summarize, I'm not sure what the legislative intent would be behind this 236 because of, the convoluted pathways that it took to get here. But those are some of the concerns of the legislators. And I worked directly with a couple of them down in their offices in Salem trying to get this thing passed. I think, there are other ways to address those concerns that mitigate the risk for pharmacists without necessarily formally putting the those kind of pathways in the protocol. And the last thing I'll say is kind of looking into what other states are doing. If you look at Idaho, for example, of course, their pharmacists operate under the standard of care practice model. And the uptake has been incredibly low from what I gather. In fact, I think it was in maybe September of this past year, there was a JAMA study that came out that looked at pharmacists prescribing. It wasn't the sole focused article, but looked at pharmacists prescribing of buprenorphine, and it accounted for less than 1% of the total overall prescribing of buprenorphine. There was also, I read, a public grant that was put out to encourage Idaho pharmacists to register with the DEA. Of course, there are a couple of costs associated with that, and because the uptake was low. And from conversations I've had, it seems like some of the reservations are rooted in their kind of fear that they're going to miss things like endocarditis or liver problems because of their inability to do a formal workup like other prescribers might be able to, and just the overall kind of lack of familiarity. So I think we can learn some things from other states in terms of rolling this out and really coupling this effort with education and outreach out in the community, from not only from the board standpoint, but state associations and other agencies, perhaps, in order to, again, it's great that we're making these protocols, but how do we get people to actually use them? And I think that's the biggest barrier that we're seeing from other states that are already doing this. I know that was a lot. Committee member Sellers, I'll turn it back over to you to see if there are any other comments about some of those points that I raised or questions.
Committee member Wickenhagen.
I appreciate that, Director Runyon. I just kind of was thinking about like an informed consent type situation, where maybe if we address it that way, this has been given to the patient, we've advised them to do this, they acknowledge that that's the recommendation. Something like that might make pharmacists more, give them some peace of mind. And then I'm not really understanding about the pharmacist part having to get a DEA license, and then also, will they be tracked on the PDMP individually? Like, do you mind explaining that a little bit?
Executive Director Runyon. Yes, that's a requirement of a prescribing requirement, and it's also written in the bill as well. So this goes back to 4002, but part of the language in Senate Bill 236 states that, and staff member Melvin will have it pulled up there for you, but essentially it authorizes pharmacists to, as the bill itself recognizes pharmacists as mid-level providers so that they can register with the DEA. I think it's section 18, yeah. Okay, section 2 there in 18. Yeah, pharmacists may register with the Drug Enforcement Administration or DA as a mid-level practitioner for the purposes of prescribing, dispensing, administering controlled substances schedules 2 through 5. That is an MOUD or medication for the treatment of opioid use disorder. So this clarifies per the law that they are a mid-level practitioner, so that then they can register with the DA and obtain that registration as a mid-level provider to be able to prescribe them. Because unlike the CDTM, the pharmacist will be the prescriber on the prescription for this, as opposed to prescribing under another provider like we have in the CDTM model. Does that answer your question?
It does. I will say I hate the term mid-level provider, but I know that's not you, so thank you.
It's better than low-level provider.
That's a very good point. This committee member Sellers. Yeah, and I appreciate this discussion. I think this is all incredibly important stuff to be considering. And I do think that sort of looking at what our, neighboring states are doing and how their rollouts are going with these types of protocols is going to be incredibly important as we decide how we want to go about doing this, because I certainly don't want to have, a protocol that nobody uses. I do think that in regard to committee member Gibbler's concern about, potentially essentially having the pharmacist be the person that people are getting their therapy from, I don't know. It doesn't seem like that's the intent of this. It does seem like the intent is really to get people started or to give them a bridge if they lose access or something like that. But I again, because this is a voluntary protocol, right? Like a pharmacist could refuse, for instance, if somebody keeps coming back and they've said, hey, I mean, I would hope that they would be able to work with that patient and figure out something in between. But I think that just the fact that it is a voluntary protocol kind of gives the pharmacist some additional leeway if they really have a genuine medical concern to not continue prescribing. If I'm misunderstanding that, Executive Director Rennion, please correct me.
Executive Director Runyon, no, that would be my take as well. I don't see a fundamental difference between this and any other therapy or service that the pharmacist provides, in that they would be able to I don't want to say refuse service, but if they chose not to offer the service, that may be a friendlier way of saying that, then they would certainly have the right to do that, just as they would fill in a prescription, for example. So that would mirror my understanding as well.
Yeah, this is Committee Member Gibbler. I appreciate the comments, and my I would think the root causes I want, as with usually many of my comments in the past, I want this to be successful, so if we're if we've developed, if there's a gap in somewhere in the protocol that can lead to someone getting into trouble, I just want to identify that, and maybe that is if they're being treated for opioid use disorder by another provider, that there's a communication and attempt to reconnect that patient with that provider at least once. And I think I appreciate the comment about the uptick by pharmacists prescribing is going to be low anyway. And I've been around long enough to know that our pharmacist culture is we're a little apprehensive anyway, taking on new roles. So we're pretty careful. And those that do choose to use this protocol will be highly motivated and probably practicing in a setting that allows them to do this work in a careful manner. So I think just that communication might help alleviate the concern that I have. And then whatever, Director Runyon, you mentioned in your comments about mitigating risks, and your ideas for mitigating risk would be good to pursue those, whatever those are.
Committee member Sellers here. Yeah, I agree with you, Committee member Gibler, in terms of mitigating risks. Also in the protocol, I believe it was question 7 or 8 that you have to make an attempt to communicate with their provider. Well, I guess it's for chronic.
For chronic pain, I think. But
yeah. Is there a way to rephrase that to just include? Or is that the next protocol? Because we're in the initiation protocol still.
Yeah, Executive Director, and I think we can easily include that in the continuation protocol. Perhaps in the question about the PDMP, I think it combines the PDMP with assessing whether or not the patient's history indicates that they've had a recent prescription without any clinically significant gaps. So we could include that because the PDMP check is there to just notify their current prescriber, previous prescriber. It's in the treatment care pathway.
Oh, separate.
Yeah, for that, in the modification. And so I think that could be an easy addition that we could do in real time.
Should we start modification? Should we just do? Yeah. Okay.
And I guess that would be a good segue to perhaps start the modification or continuation or modification protocols. A lot less information here, and I'll let staff member Melvin pull those up.
Okay, so this is going to be mailing A1. We're going to start with the cover page because we did not review this during our last meeting.
Executive Director, and so the cover page here is the, other than the title up top, is the same as the cover page for the initiation pathway.
Yeah, give me just a second. I need to see that stuff. It's giving me grief. There we go.
And committee member Sellers, I'll turn it back over to you if you have any questions. This one, again, it's the same as the initiation or induction protocol.
This is committee member Sellers. Does anybody have any questions, concerns, or comments on mailing A1, the cover page for the continuation of therapy?
Not, I'm just going to go to the next one.
Oh,
all right, there we go. Sorry, we're getting to these in a different path during this meeting for ease of use. It's not working out so hot. Okay.
Okay, Executive Director, and so we'll start with the continuation or modification of therapy, patient intake form. A lot of similarities between this and the induction of therapy protocol, with some notable divergence here. So here we're screening, again, this is the part the patient's going to answer. We're screening for previous history here, and just essentially getting good bearing on what they've taken, making sure there aren't any gaps, et cetera. And of course, we're going to verify this information through the PDMP check. The first question here, we were given feedback that it would be kind of beneficial to include this as opposed to just going down through this checklist and making our own assertions. And giving the patient our assessment is just to subjectively see what they wanted to get out of the appointment and what their intent was behind that. So question one is just, what is your reason for coming in today, and what do you hope to get out of this visit? Then we have the note at the bottom. There are no right or wrong answers. We just want to understand what matters most to you right now, and so we can figure out the best way to help you. Member Sellers, I'll turn it back to you for any discussion about that. Question number one.
This is Committee Member Sellers. I mean, I think that this is great for establishing rapport. I'm curious what other committee members think about it. I also don't want there to be barriers in terms of, just sort of time and like questions that people might feel are prying, but I think that this is a nice question, assuming that other people don't interpret it poorly.
As committee member Gibler, my only concern would be what a pharmacist, like if they would like not provide care because of a way something's worded. I don't, but also if the patient's coming into the pharmacy, they're already telling the pharmacist what they would like in order for the pharmacist to give them this intake form. So that communication's been established. Otherwise, they wouldn't be giving them this form. But I'm rather indifferent. If others think it could be helpful, I could see value in it as well.
Committee Member Wickenhagen, I agree with that. Committee Member Gibler, I don't know that you even need number one, but I appreciate it. So open for the discussion.
This is Committee Member Sellers. I'm curious for Smee Skogrand, what are your thoughts on this? Because I do appreciate that if you're already handing them the intake form, you're right. There's probably, you've already had that discussion with that patient. And I'd be curious what your thoughts are on the added value or lack thereof of question one.
I'm not sure the added value will be, because there's, I think if I remember properly, farther down, we talk about if you're still having opiate withdrawal cravings or symptoms, that might be more applicable to it. But I'm also, like Committee Member Gibler, a little bit indifferent to it. I think my only concern would be like, what if they answer a question that's not related to MOUD? And then what does the pharmacist do with that?
Committee Member Sellers is a good point. Committee Member Anderson?
Yeah, that was going to be what I was about to say, is that, yeah, I feel like while open-ended questions can be really good, especially since we're starting the whole document out with this, that I could see a lot of people being like, I'm not really quite sure what they want me to put here. Because a lot of times patients, want to be agreeable and give you what the answer that you're looking for. So I could see them trying to like search around in their mind of like, what are they trying for me to put here? And then if it has nothing to do with MOUD, what do we do with that?
This committee member Gibler, I think we should just remove it. I appreciate adding it, the reason for adding it, but I don't think it's, I think it may cause a little bit more time and a little bit of confusion in some cases.
Committee Member Sellers agrees with removal. Committee Member Wickenhagen, what are your thoughts?
Yeah, total agreement. Thank you, Andrew.
And Committee Member Anderson?
Yep, I agree.
All right.
Let's remove it.
Okay, back to you, Executive Director Runyon.
All right, Executive Director, I'm going to move to the question 2. I removed the MOUD acronym here. Of course, we can add it back in if you'd like. Just thinking, obviously they know what this is, and if we want to keep it kind of user-friendly, that it might just be advantageous to go ahead and just write it out. So what medication are you currently taking for opioid use disorder? I did leave the questions or the clarifications about the name and dosage form and then the dose, for example, here, because the patient will be filling this out. And then the note we have at the bottom, I think we amended this kind of in tandem with the patient intake form for initiation of therapy. The note says, this helps us ensure transition is seamless by continuing the same medication that's been working for you. Committee member Sellers, I'll turn it back over to you for discussion about question 2.
Committee Member Gibler, your hand's up.
Thank you, Committee Member Gibler. I think I agree with removing MOUD. In fact, I agree with removing the abbreviation MOUD in all parts except the title above where it says Section 1. That's fine if you want to define it. Because I believe there's another question where at least there was the copy that was shared, the draft that of MOUD being just abbreviated again without a definition, which is fine for those of us that are used to abbreviations, but not fine for many patients. And I think I'm going to keep my eye on that because there's other abbreviations, like we're describing something as a visual analog scale, which I don't think is necessary to even say this is a visual analog scale. And so, of course, the pharmacist forms can refer to the VAS, but I'll just keep my eye on that. I think that would be less confusing and help remove some just extra wording. And then for specifically to this question again, just reformatting the removal of the examples so it's the same as the induction intake form.
This is committee member working again. I wonder about the note, if we could simplify that to just by continuing the same medication, or we would like to continue the same medication that has been working for you, but transition and seamless. Just I worry a little bit about understanding.
This helps us ensure we continue the same medication.
And Committee Member Sellers. And then I think I know what you're referring to, Committee Member Gibler, with the like examples, but isn't
No,
this the
I made an
patient
error.
filling it
Yeah.
out?
Right
Okay.
after I said that, I realized
Okay.
that I was looking at, I was thinking about the different pharmacist form. Yeah. Sorry
Yeah.
about that.
And no, it's great. And also I love the shortening of that statement, Committee Member Wickenhagen. I think that's great. And so Committee Member Gibler, are you okay with question 2?
I am good with question 2. If we want to be, completely correct, we might put a space between the numbers and the milligrams, but other than that, I'm totally good.
I love your attention to detail, and I agree. Committee Member Wickenhagen, are you good with question 2?
I think it's
As
perfect.
edited.
And again, just appreciate this great dialogue.
Yeah. And Committee Member Anderson.
Did we, sorry, this committee member Anderson, did we land on anywhere we removed the thing, no, it's still at the bottom, but do we want to include anything in the question above itself? This says the medication that's working for you. At the bottom, it says we're asking this because we want to know what medication works for you, but we didn't actually ask that. So I'm just saying, like in the question itself, do we want to say, what medication are you currently taking for medication use disorder that has been working for you?
Or have, yeah, that and reword to have been taking, because a lot of times they may not have taken it this morning.
Oh, yeah, good. Good point. Yeah.
Might be a gap in therapy here. But I agree, Committee Member Anderson, I like that wording.
This is Steph Monroe. So do we want to rephrase this to what medication have you or are you currently? You want both in there?
What medication have you been taking for opioid use disorder, or that's been working for you, something to that effect? How did you describe it, Committee Member Anderson?
Yeah. What medication have you been taking for opioid use disorder that has been working for you?
And then strike the note.
Yeah, then we could strike the note.
And yeah, I agree. That looks better. And then can you go to the 8 and 2 and just put a space between the?
Yes.
Thank you.
Mm-hmm.
All right. So for committee members, as written, are you guys okay with number 2? I am. This is Committee Member Sellers. Committee Member Anderson?
Yeah, I like that.
Committee Member Gibbler?
Yes, I am, except the example of Suboxone film. Is film actually like the best example we give, or is Suboxone like tablets? Would that be a better example to give? Is that more people on the tablet formulation than the film? The film's kind of expensive, I think. Maybe just as an example, since more people will be on the tablet, just say Suboxone tablet as the example. Other than that, makes sense to me.
This is Committee Member Anderson. What if we just did both? Suboxone tablet?
Yeah, whatever. Yeah,
film.
totally. I just wasn't sure if film would be the most common formulation.
Yeah. Committee Member Sellers agrees and likes the edits. Committee Member Wickenhagen?
I agree. I like the sense. Thank you.
Okay. I think we can move on to question 3.
Yeah, Executive Director Runyon. I'll go through all of the components of question 3, and then I'll turn it back over to you. So the first component is, have there been any days lately when you couldn't take your medicine or ran out? Yes or no question. If yes, what do you think happened? When was the last time you were able to take a dose? And then I included this component this morning, I believe, because I think it will help us determine whether a clinically significant gap in therapy has occurred, which is part of the treatment care pathway. So the third part, question 3, is, have you taken any other opioids within the last 7 days? And this was directly lifted from the patient intake form, the initiation of therapy pathway. So the wording is exactly the same, including all of the examples. So made a yes or no question out of that. And then I modified the note slightly to reflect that change. It says a gap of more than 5 to 7 days may lower your tolerance or increase the risk of a certain kind of withdrawal if you were to restart after taking other opioids. So talking about precipitated withdrawal there, if there were any clinically significant gaps and they were taking other opioids. Committee Member Sellers, I'll turn it back over to you for discussion of question 3.
This is Committee Member Sellers. I'm thinking most of this may not be necessary, and I'm wondering if we can get rid of the note completely, because we can put that in that sort of guidance document for the pharmacist in terms of counseling. And then I can see the value of taking any opioids within the last 7 days. But again, like the top 2 questions, I don't know. I'd love to hear what the other folks think, and maybe we can start with Smee, Emily on this one, if you want to give your 2 cents first.
Yeah, I actually think these questions are important, and it's certainly something that I think about, especially, in my setting where someone comes in from the hospital and buprenorphine gets resumed on them. There are certainly things that I think about before, as when was your last dose? And then have you taken anything in the meantime? And so at the very least, I do think that the second and third part of that questions are actually really imperative to safely resuming therapy if there was a gap. And then the first one could be important if you think about, like, was there a pharmacy issue, to try and troubleshoot why the person missed therapy? Was there an insurance reason? I can see how that could be helpful in trying to figure out what exactly happened and what the pharmacists can do to mitigate that from going forward. And I do appreciate the note being in there. If you don't want to say lower tolerance, I think that's okay. But precipitated withdrawal is really scary to patients, and I would like there to be some reference to why we're asking it, because we don't want to precipitate you. And I feel like that you could potentially generate more honest answers if you have that little disclaimer, is that this could be dangerous if we don't know exactly what you've all taken in the meantime. And lastly, I would also propose that a gap of 3 to 5 days instead of 5 to 7 be, if we do end up keeping that note in there, I would really like it to be 3 to 5 instead of the 5 to 7.
Committee member Sellers completely walks back her prior statement. Thank you, Smee, Emily. That is a good point. I guess it was just one of those things where yeah. So 5 to 7 days, changing that. I'm curious to hear what the other committee members think as it's written. I'm fine with it. I was
This
trying
committee
to
member Gibler.
decrease the amount.
Yeah, that's why we have a SME here, to help us understand why these. Should there be a word after a noun after restart in the note? Certain kind of withdrawal, if you were to restart what after taking other opioids? As written, it can be confusing.
Yeah, the therapy would be fine. We wanted something in there.
Restart what therapy? Buprenorphine therapy? Is that what you're? I just want it to be very clear to the patient, because it's not even. I think.
Executive Director Running, I do agree with that. Also, we don't describe what gap means either, if we're being consistent. So a gap of what? So
Right.
If we're describing restarting what, I think it would imply it's the same thing that we're referring to in the gap. I don't mind, obviously we don't mind whatever the committee wants in terms of be more explicit, but we probably want to do that with the gap as well.
I agree.
Could you say, if you've missed more than 3 to 5 days of buprenorphine therapy, this may lower your tolerance or increase the risk of a certain type of withdrawal?
That's perfect.
Major.
Yeah.
More than. Oh, I erased it. You missed. More than 3 to 5 days.
Of course, it could be methadone, right? So it may not be buprenorphine.
This is committee member Wickenhagen. That was something that I was thinking about too, Andrew, and I appreciate that.
It's Executive Director Running, and if I guess 2 points there. I don't think. Could we just say medication for opioid use disorder here? I think that takes care of both of them. Consolidate 2 comments into one. Just do that.
This pathway is to continue buprenorphine or to modify, right? So if they were on methadone, then wouldn't we use the initiation pathway?
Oh, that's a great question. Is that very clear?
This is Committee Member Anderson. I was actually kind of thinking that when we very first opened up this document, when it had in the first question of like what medication has been working for you, you know, that what do we do if it is methadone? I guess that was kind of my question of like, we know there are methadone clinics out there, and I feel like there are like agreements at those clinics. Do we know what having pharmacists prescribe methadone would start doing? I mean, I know that's a big can of worms to open up, but I don't know. I guess in the initiation, I can't see a situation where pharmacists would jump to methadone as being the initial prescription that they would do if we know that buprenorphine is a lot safer. So I guess I'm trying to figure out like when we were looking at that particular protocol, that's what we were thinking about, you know, is that buprenorphine would be the med that we'd be jumping to. But in this case, it could easily be, if they're in treatment already, that it could be methadone. And so I don't know. What are our thoughts on that?
I can jump in. This is Emily. I can jump in real quickly. It is actually federally illegal for anyone to prescribe methadone for an opiate use disorder. It must be obtained through an OTP only. There's certainly some laws to change that where you could dispense it from an outpatient pharmacy, but it's currently illegal to prescribe methadone for an opiate use disorder, which if you wanted to make that clear, maybe in the opening statement, there could be a way to say that. And I also do think, Gary, or Director Runyon, you can correct me if I'm wrong, but I think that the law specifically referenced buprenorphine.
Executive Director Runyon. So I know Senate Bill 236 mentions the DA registration for prescribing schedules, essentially 2 through 5. But I don't know that it specifically mentions buprenorphine here. And in mirroring what you're saying, I don't know of any other protocols out there, the other states that touch the methadone prescribing either in an independent fashion like we're doing here. That's section 18.
All right, Committee Member Wickenhagen and then Gibler.
Yeah, in my experience at the Board of Nursing, we always have to caution our prescribers about this risk, and it is federal, so every state has to have methadone through an OTP. There's no exceptions, and so if there's somewhere in this document or document for the pharmacist that indicates if you get this response early on, then this is a different course of action, that might be more helpful to the pharmacists. And then we can just keep the flow of this document as, again, just buprenorphine. But if there's somewhere as a warning or a flashing light, if this patient says methadone, then this is a whole other ball of wax.
This is Committee Member Gibler. I think we need to add language if they're part of a methadone clinic. It's very clear we do not prescribe methadone. But if they didn't make their appointment this morning and now they come to the pharmacy for opioid use disorder treatment, what do we do if they didn't make their appointment at the methadone clinic this morning? And because they will come into the ER sometimes in in my hospital days every once in a while, so they may be coming into the pharmacy. So I don't feel comfortable doing anything other than saying, I'm sorry, better show up to your appointment tomorrow. But maybe adding some language that they need to refer back to the OTP would be good.
Put a star the M, but not down. By the M, medication.
Mm-hmm.
Yeah, put a star by the M. Yeah. And go down to this. Yeah, create a star underneath that.
Just a note.
Executive Director Runyon. So what we could do here, and I suppose there are multiple ways to accomplish this, when they're listing the medication name, we could put a note here to correspond to the asterisk next to medication name to say, if if you indicate methadone and fill in the blank there, whatever we want to say, that we're unable to continue to provide this service, or whatever you want to say. But this would potentially be a good place to put it.
This is Committee Member Gibler. That seems reasonable. And then to call your methadone clinic.
Could you say the law prevents us from providing methadone for you? Please reconnect with your methadone clinic or present to the emergency department.
This Committee Member Anderson, I really like that. Yeah. And that will also help pharmacists in any kind of conversations that they might have too.
Committee Member Sellers agrees.
I agree too. Committee Member
Yeah.
Gibler.
Committee Member Wickenhagen agrees as well. Thank you for that language.
Executive Director Onion. Can we get some wordsmithing on the rest of that statement here?
We are prohibited. So this should be 10th grade reading level is what we would keep.
I think what Emily threw out was the law prevents us from providing methadone.
Executive Director Onion. Yeah, I do agree with that.
We would typically cite a statute or a law if we say that, though.
Yeah, sometimes that brings up more questions than it answers and might not provide any additional benefit here. But
yeah, I agree, Director Runyon. This is Committee Member Gibler. That it might do so, and so what you've started here, just unable, is just, it's clear to everyone. Then just like full stop, and then what to do next, as Smee Skogren said, to refer to the clinic or present yourself to the emergency department if you think it's an emergency.
So end it methadone, or do you want a few words after?
You could say, please reconnect with your methadone clinic or present to the emergency department.
Because sometimes it's on a Friday afternoon and they miss their Friday appointment and the clinic doesn't open until Monday. So they'll be 3 days without.
So what was the last piece of after please reconnect with your clinic or provider? What's the next part? I missed it.
Or present to the emergency department.
We would say,
Or go.
yeah.
Do not call 911. Yeah, and you can wordsmith it. I mean, whatever, if it's, but that's essentially, I think, what we want it to say. I think there's agreement.
Or ED. We've been going back and forth.
we'll just wordsmith it.
Okay, it's either ED or
Mirror
ER.
the language with the other ones.
Okay.
You've used DD in other wording.
Yeah.
So what you have now is perfect.
Okay, do we feel okay with question 2 then for the committee?
Committee Member Sellers is okay with it. Committee Member Gibler, sorry.
I just realized if you are taking methadone, we are unable to provide methadone. I think that's, we need to clarify that. This is, thank you.
Yeah.
Now it looks clear to me. Thank you.
Committee Member Anderson.
Yeah, I like that. That helps.
Committee Member Wickenhagen.
Agree.
And Committee Member Sellers agrees.
Oh, I have a question about where you have medicine. We're using medication and medicine. So, if you want, if that matters.
Executive Director, and I think there's a question brought up about unifying the language here. We use medicine up top, but then under the note, which I think was a remnant of using the acronym, we had medication for opioid use disorder, whether we want to unify those.
This is Committee Member Gibler. At OHA, we use medicine in our plain language summaries instead of medication, if that helps.
I'm going to make the patient-facing ones say medicine if the committee agrees to that.
Committee Member Sellers agrees.
Committee Member Gibler agrees too.
Committee Member Anderson, I'm in agreement.
Committee Member Wickenhagen, I'm in agreement.
Oh, and I think we need to work.
This is me, Emily. I'm gonna channel some Andrew and say if you've missed more than 3 to 5 days of medicine for opiate use disorder, it may lower your tolerance. I think we're missing it.
And then are we ending at tolerance? Are we going to strike the rest of that, or were we wanting to keep that? I cannot remember what you all said.
This Committee Member Anderson, I would really like to keep the withdrawal part in there. I think based on what SME Emily brought up, that withdrawal seems to be one of the bigger pieces that I think concern people. So I'd like to keep at least that word in there.
This is Committee Member Gibler. SME Skogren, do you think the verbiage around it may lower your tolerance is important in the note? And I only bring it up because some patients may not know what that means or care. And it may not be important to this protocol. It might be important to the pharmacist. I just don't know if it's important to the patient.
Yeah.
And if they know what it
I don't
means.
think it's important for 3 to 5 days. I don't expect dramatic changes in their tolerance. I think that's much longer than the 3 to 5 days. And I don't think that many patients would know that. And I think to me, the point of these questions are really to help us prevent precipitating a patient.
Thank you.
Committee Chair Sellers, do we have consensus then? Did we hear from everyone to strike what I have highlighted right now?
I'll go through the whole group. Committee Member Anderson.
Yeah, I'm totally good with getting rid of that first part that you struck.
Committee Member Gibler.
Yes.
Committee Member Sellers is in agreement. Committee Member Wickenhagen.
Yes.
All right. Excellent work. Thank you, everyone. Back to you, Executive Director Wren.
Executive Director Running, move to question number 4. This was designed to essentially work in tandem with question 1 that we struck out. Just trying to tease out the reason for coming in to essentially differentiate between someone who just wants a refill and someone who thinks the medication might not be working for them. So obviously that could be accomplished solely by this question. The question 4 says, overall, how do you feel the medicine is working for you right now? So you have a few different options here. And I believe question 4, 5, and 6 together will be addressed in the treatment care pathway. Just to kind of head that off the pass, because I know we just have questions as to whether or not these are actionable. So they are grouped together in the decision pathway in the next document. So we have excellent, essentially they're stable and well managed, good, it's working, but it has some difficult moments. And then poor or fair, I'm struggling with cravings or withdrawal symptoms. And then the note there that says, this helps us understand your personal experience and whether your current dose is meeting your needs. Committee member Sellers, I'll turn it back to you for discussion.
Committee member Sellers, does anybody have any questions about question 4?
This committee member Anderson, I have one thought about that. Since we're looking at continuation of therapy, I don't see that pharmacists would actually be willing or able to, at least per this, adjust dosages. So I guess the question is this just to be able to provide feedback to their other prescriber? Or if they say here that they don't feel that their dose is high enough because they're struggling with cravings and withdrawal symptoms, would we then put them back over to the initiation of therapy? I guess I'm trying to figure out, in a pathway of thinking through this with a patient, what is this going to do for the pharmacist? What do we need to do with this information if they do say that their dose isn't correct?
Executive Director Runyon, great question. So these 3 questions together, when used in tandem, would indicate whether a patient is a potential candidate for a dose increase, which at the very end of document 3, the treatment care pathway, depending on whether their symptoms are moderate or severe in terms of cravings or withdrawals, then there is a treatment rubric for potential dose modification based off their initial total daily dose. And then, it's just based off the initial total daily dose. So there is a modification component to that. Of course, it's completely up to the committee what we want to do with that. We want to keep it altogether, modify it, etc. But there is an option for that at the end of the pathway.
Committee member Sellers, can we review questions 4, 5, and 6 in tandem and then go over to that pathway and toggle back and forth?
Executive Director. Sure.
Okay. Committee member Anderson, your hand is up.
Thanks. Sorry. Maybe this is just a clarification for me. Because I think one of the documents that was sent to us originally that we were trying to incorporate this into the continuation of therapy protocol that is for pretty much any continuation of therapy. Are we trying to pull this out and create its own protocol of continuation of therapy and therefore also include maybe modification? And if that's the case, could we maybe rename this to be continuation and or modification of therapy?
Executive Director Runyon, that's what we have at the top of this. I think it mirrors what we should have in the other documents. In trying to conceptualize what parts of these 3 options overlap enough to consider putting them in the same protocol, this is what I came up with. And that's reflected in the latter portions of the treatment care pathway as well. So for the majority of the questions and the evaluations, if you will, they're going to be the same for continuation and modification. They really just bifurcate at the very end as a derivative of how patients answer this question. So to summarize, we do have the initiation protocol and then the continuation or modification, which bifurcate at the very end of the treatment care pathway for this, are included in the same protocol. If that makes sense. Well, I can further expand on that. Yeah, when we, I guess I'll finish question 5 and 6, and then we can look at that to give you some visual, cues that would differentiate that a little more. Might make more sense that way.
Okay, so real quick, so that I don't keep asking questions like this where it could be potentially answered in the document. I've looked through my email. I cannot find this particular document. Would somebody be willing to send this to me again so that I'm not not realizing that modification was in fact included, for instance?
This is staff member Melvin. Would it be easy for you? It's on our website. I can direct you, or I could just open it on our website if you'd like. When I noticed this meeting.
Wait,
give me just a moment.
Oh, I
so
see.
If you go to our PHPFAC page, I I have this, yes, so it's two separate protocols. I feel like I understand what she's saying. Not to confuse you with the continuation of therapy that's currently here is going to change also, which we're going to talk about later, right? Because we're removing this from here. Oh, sorry, from our regular continuation of therapy. Give me just a second. Let me show you just where this is at. This may help also for the public. So on our website, on the PFAC page, Committee Member Anderson, if you scroll down to agenda, right here, special meeting agenda, all of these documents are right at your fingertips. This may be simpler.
Oh, so it's part of the agenda document?
Yeah, yes. So,
Oh, I see. Okay.
right. So if you scroll down, these are all listed right here for you. So starting with induction of therapy, and then again, we kind of got rid of all of the green and red though. So this looks a little different, but if you go to A1 is what you want to look at.
Okay. Thank you very
But
much.
there's
I
a-
appreciate that.
No worries. There's a typo right here. This is supposed to be continuation, so ignore that. This is where we are. Okay. Okay. Let me open the one.
And this is Committee Member Sellers. I actually, before we get into questions 4, 5, 6 as a group and then move on to that treatment pathway, I want to propose we take just a 10-minute break. Would that be okay with everyone? All right. Do I have to go through the whole roll call to do a break?
Nope, you will just say, so we will resume at 10:40. Does that sound right?
Yes.
Okay.
All right. Thanks, everyone.